Hello, everyone. Kyle Allred here, and we are going to do a live question and answer tonight with Dr. Howard Donner. We're excited to get into this more, going through the MedWild videos, gathering questions, hopefully gathering some questions that come in live. And you got to start somewhere. So tonight is the first night we're going to do this. So I'd like to briefly, some of you already know Dr. Howard Donner, but I'd like to briefly introduce him and then bring him onto the stream here. And Dr. Donner has been an expedition physician multiple places, including Denali, spent 3 seasons as a rescue physician there. He spent time with the Himalayan Rescue Association. He is co-author on A Field Guide to Wilderness Medicine. He's a certified flight instructor for the Finer Points of Flying, a flying company, and many, many other things, done work with search and rescue. He's a river guide. He's a professional filmmaker. So I'm going to bring in Howard now. How you doing, Dr. Donner?
Hey, Kyle. Hey, I'm good. How are you?
Good to see you. So to get things started, I'm going to jump right into some questions. And the first one comes in from Oz Ram. And he said, I've been told that one of the first mechanisms the body uses when it gets hypoxic is increased urination. I don't understand this or even know if it's true. Can you clarify this?
Well, it is true. People pee a lot, typically, especially when they're doing well at altitude. People that are not doing well at altitude often don't pee as much. And there are a million reasons for that. I'm going to go through the first 700 now for the first hour. Well, there are changes in all sorts of factors, including something called ADH, antidiuretic hormone, your renin and aldosterone system, and stuff I don't want to bore listeners with. But the one thing that people can relate to is that normally when you go to altitude, we all breathe more immediately in response to altitude. And I think most of our viewers know that, certainly if they've seen the altitude section. And when you breathe more, you develop what's called a respiratory alkalosis. You breathe off a lot of your CO2. And something that happens over time as you get to altitude is your body tries to get rid of bicarbonate, get rid of the base by having you diurese or pee off that base. So a normal adaptive response to altitude is to start to diurese and get rid of the bicarbonate, which is a good thing because when you get rid of bicarbonate, it's like baking soda, it makes your blood slightly more acid. And that works as a stimulus to breathe more, to ventilation.
Excellent.
By the way, that's what Diamox does as well, partially. Diamox has many mechanisms, but one thing that Diamox does is, in fact, that which makes you breathe more.
And since we're on the subject of Diamox, any quick recommendations on dosing? When I was going through the questions today, a lot of questions came up about Diamox or acetazolamide dosing.
Funny. In wilderness medicine, things don't change that quickly. But recently, and when I say recently in wilderness medicine, I mean within the last 50 years. No, but within the last year or so, there have been a couple small studies showing that really small doses of Diamox seem to have the same efficacy, which is just the medical term for effectiveness, as larger doses. So how big? So the typical Diamox trade name tab, typically the pill itself is 250 milligrams. And a lot of experts over the last few decades have said you don't need that much. Just take a half a tab, which is 125 twice a day. And there are a bunch of side effects associated with that we can go into sometime. But now there are some studies showing that maybe just a quarter tab, which is 62.5, and it has to be exactly 62.5, not 62.4 or 62.6. But if you just break a tab into quarters, that the efficacy seems very similar to a half a tab or 125, but the side effects, the most bothersome, I think, is numbness and tingling, so-called paresthesias. The side effects go down, but the efficacy for altitude seems similar.
Great.
And that's twice a day. So So 62 to 125 milligrams twice a day.
Okay. So if someone gets a prescription for 250 milligram tablets, be ready to cut those in half or quarters.
Yep.
Okay, I'm going to move on to hypothermia. And I had never heard this question before, and so I'm hoping that there is a simple answer to this. This is from Fred. He said, I've been told that one way to check for hypothermia is to touch your thumb to your pinky. And if you can't touch them together, you are in a state of hypothermia. Is this a good test? And if so, would it be mild or severe hypothermia that one is experiencing?
Is this a good test? Well, let me put it this way. No. I don't know if I talked about this in the MedWild segment. I don't watch them because I hate that guy. But I don't know if I talked about local neuromuscular cooling. I think I did when we talked about immersion hypothermia. And I used to live in Telluride, and I remember being on a lift there. It was a famous lift that used to break down a lot, but whether it broke down or not, always pretty windy, very cold. And friends would call me, and I'd pull out my cell phone, and they'd go, "Hey, Howard, how you doing?" And I'd go, "Good." They go, "What's wrong with you?" And I go, And I wasn't hypothermic. It's just the wind had been blowing on my face, going up a lift on a windy ridge, and the muscles and nerves in my jaw made it really hard to talk because they were cooling. That's the same thing that causes swim failure, which, Kyle, I've heard you talk about in your Whitewater talks. Maybe we can do some Whitewater stuff, in upcoming installments of MedWild. But
Yeah.
But when you can't move your fingers, that is a function typically of local muscular cooling. It could be related to something central. But I would never use that as an indication. It mostly suggests that your extremity is cooling. And certainly if your extremity is cold enough that you can't move your hands, that's not a good thing. But it doesn't correlate specifically with core temperature.
Got it. Thank you for that. And I'm going to drag in a question here. And this just came in from username JSTodo or JSTodo. How long should you take the Diamox? We were just talking about Diamox. So Howard, you talked about dosing. How long should that continue?
So the answer to that is equal to as many doctors that prescribe Diamox. I know a lot of doctors. I've worked in clinics where other doctors have said, "Here, just take this while you're on your trek, or you're going to Kilimanjaro. Take 1/2 tab twice a day until home," or whatever. It's not my style, and this is a matter of style and it's a matter of philosophy. Taking Diamox is pretty safe, assuming you don't have any contraindications. There are some allergies and some other things that we're not going to talk about now. Talk to your doctor that prescribes it. But I feel like doctors in general are really good at getting people onto medicine, but they're not as good about getting people off of medicine. So if I'm with somebody on a trek and they're taking Diamox and they're at the front of the group and they're eating like a pig at night and they feel energetic and their doctor put them on Diamox, they'll say, "Hey, should I keep taking the Diamox?" And I'll say, "No, why don't you try stopping it?" And then if they get worse the next day, I'll tell them, "That was a bad idea. You should start taking it again." But oftentimes, if somebody's doing really well, they'll be fine without it. If somebody's marginal, I'd keep them on it. So what am I saying in my usual long-winded way? I am saying I watch the trekker, the climber, the skier, and if they look great, I'll suggest that they maybe take a half of whatever dose they were on and see how they do and then just get off of it. But there are doctors maybe listening to this that would say, no, they should keep taking it as long as they're at high altitude. It has never been my style in the past.
Excellent. Thank you for that. Okay, back to hypothermia. A lot of questions about hypothermia. And Green Ash R47 wants to know, What about laying a severely hypothermic patient near a fire? I've heard that's not good to lay them near a fire, but I'm not sure why.
So these are hard questions because this one is a bag of worms. So there's a lot of stuff in the literature, never do this, never do that. That whole idea about fires or throwing people into hot bathtubs is because people worry about something called rewarming shock. And the idea is that you're maximally vasoconstricted. You put somebody by a warm fire, they start to vasodilate. They have insufficient fluid because typically you don't have IV fluids. They're not in a hospital environment. So they vasodilate and they get shocky and they die. There's also theoretically, although this is argued, a return flow of, acidotic, hyperkalemic, that's potassium, high acid blood returning to the heart, which can cause the heart to do bad things, like fibrillate, which is a non-perfusing rhythm of the heart. So people, doctor types just say, don't put somebody by a fire. And that works if you're out with the Boy Scouts and you're camping at the lake near your house and you want to get that person to the hospital. But it doesn't really answer the question, what if you're in the middle of nowhere? And the simple answer is, if you just keep letting the person cool, they're going to die. So the idea is gentle warming, probably not putting them by a super hot fire, but the best way in the field to add heat is to areas of high heat transfer, like the anterior chest, lateral chest, also known as the armpit, the belly, the inguinal area. I would stand up and show you, but I'm not wearing pants. The head and neck, and just use warm water bottles wrapped in fleece so you're not burning the skin, and try to just gently add heat to areas of high heat transfer. Putting somebody that's shocky or potentially shocky really out to lunch, throwing them into a hot tub or putting them by a burning fire. Some experts worry, as do I, about rewarming shock. So rewarm them gently.
Got it. And briefly, rewarming shock is
the fact that you are maximally vasoconstricted when you're cold, typically,
yep,
and inducing a rapid vasodilation of the extremities. In theory, a lot of this is theoretical, in theory could drop the victim's blood pressure to the point where they basically have a heart attack and die. It's not a heart attack, it's a bad rhythm like ventricular fibrillation, which stops the heart.
Got it. Okay, shifting from the cold and altitude to shoulder dislocation. And Howard, you have a great MedWild series about how to recognize and reduce a dislocated shoulder. So this is a question from A. Mills. He said, in pre-hospital care, we are told never to reduce a dislocated joint out of fear that nerves or blood vessels may get caught in the joint. In the wilderness setting, where it makes sense to reduce the dislocation, or if the relocation happens spontaneously, what do you do if there's a loss of neurological function or circulation distal to the reduced joint? Or is this even a valid concern?
Well, yeah. So I'm not an orthopedic surgeon, but as you know, I've done a lot of ortho in my life, working in emergency rooms at ski areas and such. But I talk to billions of orthopedic surgeons, and I don't know an orthopedic surgeon that would tell you not to reduce an injury in the field if there was a distal nerve problem, because you have a 99.99% chance. I made that up, by the way, but basically virtually reducing that dislocation, if anything, is going to decompress the nerve, is going to take whatever impingement is causing that dysfunction, it's going to reduce the pressure. So most orthopedic surgeons would say if the person has some numbness or tingling and a dislocation, assuming there isn't a fracture and assuming there are no other contraindications, reducing it will most likely help. Um, I guess the question would be, and I don't know if this is what the viewer is asking, but what if you reduce it and it gets worse? I've never seen that.
Yeah.
It's hard to imagine, but I suppose that's a possibility that you could reduce injury and pinch a nerve. But again, I've never seen that. I've reduced lots of dislocations.
Got it. I had a question regarding dislocations. The technique that you demonstrate, I think, is called the Snowbird Technique. Is that right?
Informally, yeah.
Yeah.
Snowbird technique, right.
Has that always been your favorite, or did you transition to that after, playing around with different techniques?
I used to use the one that they show in just about every wilderness medicine textbook where you lie down and pull back with sheets or fleece. I just found that just leaning back, it didn't always go in as quickly. And sometimes I would be working it and it wouldn't go in immediately. When I first got out of medical school and I was working in emergency rooms, even before residency, after my internship, I guess, I used to use the gravity technique where you put somebody on a table, prone, face down, and hang weight on their wrist. You don't have them grab it because then they're flexing their shoulder. Yeah. You duct tape something to their arm and you're just pulling it down. And everybody says this works great. You see that in wilderness medicine texts. In my experience, it takes a while. And sometimes in a busy emergency room, I just wanted to get the patient going. So the Snowbird technique, doing the distraction or traction towards the floor with a little gentle external rotation, which I think I showed in that video, I have found just works more quickly.
How about for someone by themselves in the wilderness, kayaking by themselves or hiking? Would that technique work as well then? Tying something to your wrist and just letting your arm hang?
Well, you're not just the prone method. Yeah, that would be a great method. And if you're a kayaker, you could put rocks in a helmet for weight. If you're on a river trip, there's usually, back in my day, we had bailing buckets. We'd put water in. But you don't go on river trips anymore with bucket boats. But most river trips have a pot or a big bucket for getting water. So just hanging weight on the person's arm is a good thing.
Excellent.
I'm not against that technique, mind you, but you asked me what I use, and I find that technique didn't always work immediately. Because what you have to do is you have to sort of wait for the voluntary and involuntary muscle spasm for those big muscles to just relax.
Right.
And that can take a while.
Okay, another question here. Had a few questions on the channel about your experience, Howard, as an expedition physician and or clinician at high altitudes, places like Nepal, Himalayan Rescue Association in Nepal, on Denali. So if you could just speak a little bit to how you got into that and what your experience was like in those locations. And did you get lonely?
I did get lonely. I actually proposed to my wife on Denali one year, and when Rob Roach was the rescue research station director, and he was on a rescue, and I was by myself at 14,000 feet, and he was down with a ranger, and I literally was by myself at 14,000 feet. He and the rangers had gone down, and when they came back, I said, "Guess what? I proposed." And he goes, "Oh my God, no." And I said, "Yeah." He said, "You should never propose to somebody when you're lonely." So
sage advice.
But anyway, Denali is a great place to work. I think it was the richest wilderness medicine environment in terms of the severity of injury, trauma, climbing injuries, plus high altitude and the whole gamut, HAPE, pulmonary edema, HACE, everything. And the thing, if listeners want to work there and you're a doctor type, The one thing that the Park Service used to require, I assume they still do, is they won't let you work there unless you have at least 1 season experience climbing in the Alaska range, preferably on Denali. You don't need to summit, but you need to have at least spent a season there, because they're worried that the doctor, you might be a really good climber, and you're a whatever 514 rock climber and a great emergency doctor. So of course you'd be perfect on Denali, but then you get up there and you don't even know how to take care of yourself in that kind of cold. And so other people have to start taking care of you. They don't want that. They just want you to have 1 season in that kind of cold. And it's really cold up there. It can be 30 below zero and big wind, etc.
How long were you there? How long did you spend each season?
The climbing season is usually about 3 months, and the patrols are a month, and usually they're a little early and you overlap. They're smart about that. The worst thing you can do is for a doctor to get up to 14,000 feet, and then the other doctor that's there on the patrol before you goes, "Hey, good to see you. See you later," but you're worthless for 1 or 2 or 3 days typically. So typically there's an overlap, so you can sort of just stand up there and drool for a day or two until your brain starts working.
Got it. And then how about Nepal? How was that experience at the Himalayan Rescue Association?
So that's similarly, it's an amazing experience. You're in Manang, where I worked the first time I worked there, about a third of it was local healthcare. So you're not just dealing with trekkers and altitude stuff. But yeah, it's really good. You see a ton of diarrhea, a ton of altitude illness, and then lots of, suturing and little sprains, dislocations, the usual. They have 3 stations. They have one in Manang, which is the Annapurna circuit, one in Feriche, which is the Everest Base Camp circuit, and then Luan Freer, a decade or so ago, or more now, started the Everest ER, which is the Everest Base Camp HRA. And at least last time I checked, to work at Everest Base Camp, you have to have spent at least 1 season at one of the trekking aid stations, either Feriche or Manang.
Got it. Let's see. So I wanted to ask at least one question about rescue technology, because I know you know a lot about that, Howard. And this is a question from username Turkish Ninja. Please explain the main differences between EPIRB and PLB. And I'll add to that if there's any rescue technology that you're particularly excited about at this time.
Yeah. Well, the simple answer, this is not the answer, but the simplest answer is there is no difference, in that the brains of a PLB, basically a 406 megahertz rescue device, works the same as an EPIRB. So they're the same. But the difference is that to certify an EPIRB, it has certain requirements. And there are different classes of EPIRBs, some that are self-activated and some that aren't. But the important thing is that it's a function of battery life. Typically, you can go to the regs and read all this, but PLBs have to be able to transmit, I believe it's for 24 hours, whereas EPIRBs have to be able to transmit for 48 hours. EPIRBs are required to float with the antenna in an upward position, whereas a PLB isn't even required to float, so it could sink. The level 2 style EPIRBs activate when they have a hydrostatic release, and they will release and actually activate when they go underwater, whereas PLBs have no requirement for that. PLBs require typically a 2 or 3 step process to activate. So you have to remove a lock and then activate it, or sometimes even 2, whereas an EPIRB may be designed to just go off automatically if the boat sinks. So most of the differences have to do with battery life, the battery life itself, and the operational endurance of the unit, the antenna, and the way it's activated.
Great. Okay.
Oh, and I thought rather than me continuing to go on here. I know, Kyle, you uh, were an early adopter with the Delorme InReach.
Hmm.
And, for years, as you know, I've talked a lot about um, PLBs and spot messengers and such. But I think the world sort of changed when Delorme came out with their InReach, and now Spot makes a similar model. So I think it would be more interesting to have you talk about. I've used InReaches. I just delivered a sailboat this winter, and we used the Delorme quite a bit. But I know you've used yours a ton, and I'm curious what your experience is, and if you don't mind telling listeners what the difference is between your InReach and something like a PLB.
Yes. So the InReach Explorer is the big advantage of that over something like Spot is that you can actually communicate with a text message. So it's got an interface where you can either hook it up to your phone and actually write out a text message and have two-way communication. So if I'm out in the wilderness and I have a problem and I want to let Howard know I need help or I need specific equipment or any details, I need a winch on his truck to pull me out of a ditch, something like that, I can get that specific message across to him. Unlike a Spot, which is it's all or nothing. It's like, hey, I'm here and these are my coordinates, or call in the cavalry, call in the search and rescue. So that's a huge convenience in an emergency situation, and even in non-emergency situations. You're up at a ski cabin or something, you need a resupply. It works well for that. I know people that travel internationally with the InReach Explorer and just use it as a text message platform for that. There's something new that I haven't tested yet. I'm curious if anyone watching this has. It's a product called Bivystick, and it's has a lot of the same features that a Delorme InReach Explorer has, but it's a little bit cheaper. And I think the month plans, the per month cost might be cheaper. It also gives you a charge. So if you need to charge your phone from this small device, you're able to do that. So a lot of potential advantages. I haven't tested it myself, but I'm looking forward to getting my hands on one of those soon. And speaking of this topic, I want to add Bill's comment here to the live stream. He said, EPIRB holds international maritime approvals by SOLAS, SOLAS, safety of lives at sea. Any comments on that, Howard?
Yeah, I mean, he's absolutely right. I didn't talk about certification, but if you are a commercial passenger vessel, fishing vessel, etc., SOLAS is certification is often required depending on what kind of operation you have, whereas a handheld PLB will not be certified.
Excellent. Thanks for that comment, Bill. And then Howard, I'm going to get you out on one last question here before we end the live stream tonight. And we're going to hopefully try to do this more often. And it's from Jeffrey Jordan. Is hands-on CPR recommended for a drowning patient, or is mouth-to-mouth along with compressions still recommended? And I know that's very specific, and it changes.
You know what we should do is, I mean, I have strong opinions about this, but I really do not want to promote any misinformation, and I want to make sure that what I'm recommending is in line. So I think we should talk to our good friend and colleague, Dr. Eric Weiss, who is a drowning expert professor at Stanford. And why don't we lead off in our next session with that?
Sounds good. Thanks for the question, Jeffrey. And Howard, any parting words before we sign off here tonight?
Remember, only you can prevent forest fires. No, wait, that's something different. No, this has been really fun, Kyle, and I hope that this sort of inaugurates a new era where we can try to do this, keep it pretty frequent, like once every 3 to 4 years.
Yes, yeah, exactly. And
I would love to do this as much as we can. I know both of us are kind of crazy busy, but it'd be fun to come back and do this more often with maybe some frequency, a few times a year at least.
I agree. And for our MedWild viewers out there, this was kind of an impromptu session. Howard and I wanted an excuse to get on and chat, and also look through your great questions and try to get the ball rolling with more of these sessions. So thanks for joining us. If you're with us live or if you're watching the replay of this, and we'll hopefully see you soon. Thanks, Howard.
Hey, thanks, Kyle. I'll talk to you soon.
Okay.
And see everybody. Thanks for joining us. We'll catch you next time.
So long.